Good morning for the people who are in the other side of the Atlantic. Good afternoon for everyone. And I think that even we have a good evening to say to Indian people. So welcome to ISOP Israel and to our Tell Us a Case Safety Story. This is now the second season. And we are very proud to start this week because this week is the WHO Med Safety Week. So we are part of international movement and we are there in ISOP Israel. So what is the rules of the game of this new concept that we have created? First, this is something that we want to set up twice a month. First Wednesday in English and with our partners, and second Wednesday in Hebrew. The idea is to present one or several cases in the same topic, and then to discuss, to analyze the cases, and to discuss how can we prevent or minimize this adverse reaction? How can we prevent that it will happen again? So it's a 30-minute online event. It's free, and we have one objective, which is to train healthcare professionals, not only from pharmacovigilance, but all healthcare professionals. When they are facing an adverse reaction, they have to think proactive. What does it mean? It means that everyone should ask himself or herself, what should I do to prevent this to happen again? And I think that I have started my first job in pharmacovigilance in asking myself this question, and it has led me all my career to advocate for risk management and risk minimization actions. So if you want to present a case, if you have something interesting to present, contact us and we will be welcome to participate. We have several partnerships. We are very glad to have like a little consortium of chapters from Latin America, North America, Italy, and Switzerland. In our last events, in July and in September, we had participants from 18 countries and 4 continents, which is really, thank you, COVID, we could say. And then in the frame of our partnership, we are collaborating with NASOP annual meeting, the North American ISOP chapter, and the topic will be the impact of COVID-19 pandemic on pharmacovigilance, drug development, and healthcare practices. We have also other partnerships, of course, with Bioforum, hosting us all the time and supporting us from the very beginning for 7 years. The ISMP Institute for Safe Medication Practices, NIDIMED, BMedWise Patient Education, Mother Risk International, and Alliance for Patient Safety. And now I want to introduce our distinguished speaker, Dr. Marco Tuccori. Marco is a pharmacist and a PhD in pharmacology and clinical epidemiology. He's a pharmacovigilance manager of the unit of adverse drug reaction monitoring in Pisa and the coordinator of the Regional Center of Pharmacovigilance in Tuscany. He's also acting in the drug agency, Italian drug agency, and is involved in the signal detection, and is also the coordinator of the Italian chapter of ISOP. He's teaching pharmacovigilance in Pisa and is writing many articles and chapters of books. Thank you so much for accepting our invitation. And please, Marco, tell us about your program.
Okay. Thank you, Irene, for your presentation. Let me share my video. Can you see?
Yes.
Okay. So let me thank Irene again for inviting me to provide this presentation and even to start this new series of seminars or webinars about the presentation of cases. When she contacted me a few weeks ago, I had some initial problem to decide which case I could have presented, considering that the objective of this webinars would be that of identifying cases for which maybe some minimization risk could have helped in preventing adverse drug reaction or even the consequences of such adverse drug reaction. And I remember that in 2008, I published this case on platelets, a journal of hematology dedicated to hematology or to blood diseases. And therefore I decided that this could fit somehow with the request made by Irene. Before starting this presentation, I would like just to make an introduction about the value of case reports as contribution to the scientific evidence, because usually when you talk about the quality of scientific evidence, you talk about this kind of presentation, the so-called pyramid of scientific evidence. And you can see in this picture that case reports are at the bottom of this pyramid. So they are considered one of the lowest level of quality when you talk about scientific evidence. But I remember very well one of the first presentations I've had when joining the ISOP in 2005, a presentation made by Jeffrey Aronson. You know, he is a lecturer in Oxford, clinical pharmacology lecturer in Oxford, and he worked a lot in the classification of adverse drug reactions and also in providing rules for causality association in when you analyze the case reports. And I was impressed by the fact that he said that you should consider not a pyramid of scientific evidence, but a spectrum of scientific evidence. And case report can contribute a lot to this spectrum of evidence, particularly and you have to, when you need information on some event, like in this case, which cannot be studied in large population because extremely rare. In that case, maybe case report become one of the best opportunities you have to provide evidence of some particular event. And therefore, from that time on, I started working on case report. Several case reports between 2000 and I started working in pharmacovigilance in 2001, and up to 2010 I published some case reports, and it was easier at that time because journals were more prone to accept case reports as publication. But later the majority of journals decided to exclude this kind of publication from the possibilities for authors, and this was because I think that providing cases maybe with sufficient quality would have not been so easy or so frequent from authors, whatever the case they are presenting. So what I would like to say is simply that maybe we need to reappraise case reports as a form of communication, particularly for drug safety. And I think that this series of events organized by Irene would be supportive direction. Okay, let's come back to the presentation of this peculiar case. This case was generated in 2007 when I was contacted by the colleagues from the Institute of Forensic Science and Toxicology, which is just upstairs from my hospice, because they need a consultancy, pharmacology consultancy about a case that they have. And for which the judge of the tribunal had requested a consultancy to the forensic science because it was not clear whether there were responsibility or something like that, particularly of clinicians. This case occurred not in my hospital, but in an hospital close to mine, and the tribunal used the forensic science as consultancy for deciding about that. At that time, we decided to start activity of consultancy, of pharmacological consultancy in our hospital by creating this unit, the denominated Unit of Adverse Drug Reaction Monitoring, which provide many kind of consultancies to the whatever the word of the hospital, particularly focused on drug-drug interaction requests and adverse drug reactions. The most frequent situation we have is when you have a patient, the patient has a lot of comorbidity, a lot of polypharmacy. You have to introduce a new drug in this patient because of a new morbidity or new disease occurred. And so they asked us usually whether this drug is appropriate, whether there are risks of adverse drug reaction. And I think that somehow we have avoided the occurrence of some interaction which may have led to important adverse drug reactions in the past. So I think that this is somehow a way for minimizing the risk linked to the use of drug in the hospital. But in this case, the patient was already dead at the time of consultancy, and we collaborated with them to identify whether there were responsibility as required by the judge. It was a 30-year-old Caucasian man, so very young, which reported at the emergency department with abdominal pain and jaundice. Not that it was reported in his patient past medical history. He is young, he was young, so he has no comorbidity, he has no co-medications, and it was a simple patient, an easy patient to handle in the perspective of having usually patients with comorbidity and polypharmacies. 3 days before the presentation in emergency department, he had spontaneously initiated oral ciprofloxacin, 1 gram per day, for a suspected urinary tract infection, macrohematuria, and right lumbar pain. The patient was not taking other drugs concomitantly, and no history of ciprofloxacin intake was reported. So we have no idea on whether he could have had an allergy, for instance, or some problem with these drugs, because it was the first time that he assumed the drug, that he took the drug. So what is not reported in the publication, because at that time my boss, which was not very in pharmacovigilance, thought that for having more chance of having our article accepted by the journal, we should have said that the patient was taking the drug under the prescription of his physician, which is completely wrong. I think that to emphasize the risk of drug, you should describe even situation in which a drug was taken not appropriately with the indication or with the prescription of the physician. And that's the in this he self-prescribed ciprofloxacin because this drug was already taken by his girlfriend for a urinary tract infection, a form of cystitis, few days before. And he suspected to have the same infection sexually transmitted. So he decided to take the same drugs. Moreover, he has taken ciprofloxacin tablets remade in the box used by his girlfriend and stored at home. All of us have the classic medicine drawer or the medical, whatever the box in which you store your used medication, right? And this represents a sort of danger that you have to consider in your house at home. At day 3 of treatment, so after 3 days that he was taking ciprofloxacin, although macrohematuria has disappeared, maybe the drug was also effective. So he was treating quite well the urinary tract infection. He started complain abdominal pain, fever, and jaundice, and he decided to go to the emergency department. At physical examination, mild jaundice and dehydration were also noted. Abdominal ultrasonographic evaluation detected areas of renal hypoperfusion consistent with a diagnosis of focal right pyelonephritis. So an infection localized in the kidney district, bacterial, because of pyelonephritis, a bacterial infection. Analysis revealed signs of hemolysis and severe thrombocytopenia. And you can see the clinical picture and the values recorded for some blood parameters at that time here in this table. As you can see here, we have the parameters recorded at admission, 4 hours after admission and 12 hours after admission. Of course, it would have been, the gold would have been having the parameters before the intake of ciprofloxacin. But as you know, because all of you work in pharmacovigilance since many years, or the majority of you, it is quite hard to have such information in this situation. So we have just to compare what we were able to capture in terms of data at the time. And as you can see here, we have extremely severe thrombocytopenia at admission and after 4 hours. We have an improvement after 12 hours because of the treatment, but this improvement was not sufficient to save the life of these patients. And peripheral blood smear showed occasional schistocytes, some immature myeloid cells, and megakaryocytes. Direct antiglobulin test was negative. Blood and urine culture did not show any bacterial growth, but this finding were obtained after patient death, so as a post-mortem finding. A diagnosis of severe thrombocytopenia associated with hemolysis and right pyelonephritis was made, but the evaluation clinical picture suggested a thrombotic thrombocytopenic purpura. Accordingly, the patient was rehydrated, plasma exchange was programmed, and a treatment with methylprednisolone 2 grams intravenously was started. However, owing to temporary unavailability of plasma exchange machine, and in the attempt to ensure a salvation treatment, clinician decided to stop hydration and to start plasma transfusion. This is probably the most critical key element of this case in terms of the responsibility of the physicians, of course, because this would have been the best treatment available for treating this condition. And the consultancies that the forensic science asked to us was that of analyzing whether the alternative treatment that they issued at that time was, however, somehow enough to treat the patients and to try to save the life of the patients, because they decided to use this plasma transfusion. And we found in the medical literature that this procedure is regarded as appropriate intervention for patients with thrombotic thrombocytopenic purpura when the plasma exchange is not readily available. This is the evolution of the clinical picture. They considered that maybe the initial diagnosis of thrombotic thrombocytopenic purpura could not be the right one. They thought that maybe considering an immune component would have been a good thing to do, and they decided to use also gamma globulin to try to improve the condition of the patients. But the patients, despite all this intervention, in the following hours developed vomiting, confusion, and cold sweating, and in concomitance, a progressive appearance of petechia and purpura on the thorax and lower limbs occurred. This is not a picture of the patient. This is just an imaging that I had taken from Google Images to show what was the picture in terms of petechial manifestations in the lower limbs of the patients. They used also tranexamic acid in the attempt of limiting the blood loss, but 17 hours after the admission, the patient died for cardiopulmonary arrest, despite the efforts of resuscitation. And this is instead the heart of this patient, from the report for the tribunal provided by the Institute of Forensic Science and taken during the autopsy of the patients. And you can see that even all the internal tissue of the organs were covered by petechial hemorrhages, as you can see here. I remember that in 2008, when I was quite younger than now, I was enthusiastic when I such an evidence, because when you work in pharmacovigilance and you work in spontaneous reporting, it is extremely hard to have a so good quality of evidence to support your publication and your cases. So, you know, at the time I feel myself like a sort of vulture that was quite ready to go on the prey. This case was these poor patients, to have information that could be valuable for our purposes. And you can see that at autopsy, external examination show a jaundice and skin petechial hemorrhages. Petechial bleeding and other signs of edema and hemorrhage were detected in several organs, including the brain, the cerebellum, the lungs, the liver, the bladder, and the myocardium. This is another picture that I've taken from Google, just to show you what is the histological picture of hemorrhagic pulmonary edema. The patients had no signs of abscesses in the kidney, so maybe pyelonephritis can be ruled out, even as a potential cause for the thrombocytopenic event. The histopathological examination revealed hemorrhagic pulmonary edema, as well as hemorrhagic extravasation in the myocardium and hepatic globules on kidney. There were no signs of bone marrow depression at the histological examination. Moreover, they analyzed a sample of tissue from brain, cerebellum, lungs, liver, kidney, bladder, myocardium. They were not able to reveal the presence of any kind of thrombi or sign of heavy microangiopathies in capillaries or arterioles. This finding allow us to exclude that the correct diagnosis of thrombocytopenic purpura, because it was not a thrombotic. Thrombi were not detected at all in the vessel of these patients. And neither microangiopathies, which are the main causes of this massive aggregation of platelets in case of thrombotic thrombocytopenic purpura. Blood examination with gas chromatography and mass spectrometry revealed a ciprofloxacin concentration within the therapeutic range and excluded any intake of recreational drugs that could have somehow contributed or even triggered the thrombocytopenic event. In here you have a general representation of the process of differential diagnosis associated also with the identification of the potential mechanism by which this thrombocytopenic event could have developed at the time. We started with the most important symptoms, which is the severe thrombocytopenia. There are several ways in which such a thrombocytopenia could manifest, could occur. One of the first is the bone marrow depression, so a reduction in the synthesis of platelets. And but we did not find any kind of bone marrow depression, so we can exclude this mechanism. Another one will be that of thrombotic thrombocytopenic purpura, so a massive aggregation of platelet, but we did not find any kind of thrombotic clue in the blood or in the vessel of the patients, so we can even exclude a massive aggregation. What remains is mechanisms that include the contribution of immune system. This form of purpura are called idiopathic thrombocytopenic purpura, and they are caused by the production of antibodies, drug-dependent antibodies in this case, that can destroy the platelets and therefore providing this picture of severe thrombocytopenia. If this is the correct diagnosis, what are the possible causes? The first one is infection, but we excluded infection during the postmortem evaluation at autopsy. Cancer was excluded as well at autopsy. We excluded also the contribution of other drugs, including recreational drugs, and therefore the most probable suspected causative agent remain ciprofloxacin. When you think to ciprofloxacin and you analyze the medical literature, you can find that this kind of action was already described, although rarely in the medical literature, because even ciprofloxacin, but even other fluoroquinolone antibiotics have been associated with thrombocytopenic event and hemolytic events. We know that these adverse events rarely develop within less than 1 week of treatment. So the temporal plausibility of our case was quite harder to define, because it occurred in 3 days, and I suspect that it occurred in few hours from when the patient started taking ciprofloxacin, but maybe he delayed the access to the emergency department because maybe he cannot imagine to have such a situation ongoing at that time. So it was also a problem of delay of the patients in accessing the emergency department at that time. But anyway, considering what is the mechanism of this adverse reaction, I think that the relationship remain plausible. Of course, we have excluded a lot of alternative causes. For some of them, we cannot exclude quite a minimum, at least a minimum contribution to the development of the event. But I think that the contribution of ciprofloxacin is almost definite. You can see that more or less 1 year after the publication of our case report, this was a review published by this group from Australia that provided the point, the status of the art about the problem of immune thrombocytopenia associated with fluoroquinolone antibiotics intake. So I think that if we calculate the causality assessment, even using a standard algorithm like a Naranco algorithm, we could have scored a association with ciprofloxacin, considering the available evidence. What is the mechanism? Why I have said that maybe even few hours are a plausible temporal relationship for the development of this adverse drug reaction. It is thought that there are some naturally occurring antibodies with a weak binding capacity to some antigens which is located on the membrane of platelets. But these antibodies are drug-dependent antibodies, and this means that in the presence of drugs, this affinity improves a lot and becomes stronger, and therefore antibodies can attack the platelets and destroy the platelets even quite rapidly in the intake of the drug for the very first time. And this mechanism, in my opinion, can explain very well the event we have observed. So this is my last slide, in which I have tried to answer to a sort of set of question that was maybe with the aim of this series of webinars that we started today, which was how to prevent it to happen again. What can be the actions and what should be the contribution of the different stakeholders involved in the management of these cases. Well, I thought I've started thinking about this before providing this presentation. I'm not sure, of course, that I have covered all the possible minimization measures that we can issue to prevent such adverse reactions, and I hope that this could stimulate the discussion at the end of the presentation. What I think is about a major role of the prescriber, although the prescriber was not involved directly in this adverse drug reaction because of the self-prescription of the drug by the patients. And here we have a couple of situations because, of course, there is this famous medicine drawer at home, in every home, that is somehow under the control of whatever the healthcare professional, pharmacist, or the doctor. And I think that maybe the prescriber should educate the patients to consult him in the case they have to use some medicine remedied from previous treatment stored in this medicine drawer. I am not sure. Maybe this patient would probably have received the same prescription of ciprofloxacin, even in the case the prescriber was involved. But anyway, better supervision by an healthcare professional could have improved the situation. Maybe identifying, for instance, early symptoms of thrombocytopenia instead of being at the emergency department with 10,000 platelets for cubic millimeter in these patients. So the prescriber could have educated the patient also to identify signs of any illness that could have been related to the drug. And this is what I think. I have also remembered that some after this case was published, my boss at that time received a request from the son of another professor, which had to take the same drug, ciprofloxacin. And since he knew that the mother and the father of him suffered of autoimmune diseases, he decided to prescribe ciprofloxacin to this guy. But he asked also to check for platelet counts in the day after the beginning of the treatment. And we were lucky because during this check, he observed an initial reduction of platelet counts. So he stopped the medication and switched to another drug. It was not a fluoroquinolone antibiotic. We know they are the best for treating urinary tract infections. But in that occasion, we were lucky because probably he saved this patient from another event that could have replicated the one I have just described. Maybe not with the same outcome, because luckily these events usually have a positive outcome, and not the patients rarely can die due to such adverse drug reactions. But anyway, I think that somehow, in some way, this case report helped us to prevent another similar event. I was not able to imagine a particular contribution from industry, but I'm sure that maybe some one of you could imagine what could industry do to prevent such kind of cases. While I think that both hospital and academy could support the creation of unit like my unit, which are units that are here to support the prescription activity of whatever they prescribed in the hospital and even outside the hospital. And we can help preventing some critical situation in particular in patients that are receiving a lot of drugs, and new drugs should be there is the need for adding new drugs to a polypharmacy that is already ongoing. Nothing. I think I finished. So thank you very much for your kind attention. I can.
Marco, leave your last slide.
Okay.
Okay. Thank you so much. It was really fascinating, this case. It's terrible and really fascinating.
We were particularly impressed at that time because the patient was very young. So yes, it is quite difficult really to accept that young people can die for such a situation, you know?
Yes. I have several questions coming during the presentation and also during this last slide, and about the drawer. I think that in fact we can say that I just realized that in this template that I have given, I have forgotten the patient.
Yeah. I had to realize this before of you, because in particularly in this case, I have demonstrated that the role of patient is extremely important, and the education should be crucial for preventing such kind of events.
We could say that about the patient, that when you have a drawer with a full of medication, usually the patient leaflet is not more available, and no. I don't know how much the company are highlighting these cases, this adverse reaction that they have to stop immediately. And I think that there is a lot of adverse reaction where to stop the drug is crucial. And it's something that I would like to really to advocate, to use some specific infographic, like on the packaging, that you have to look at something specific in the patient leaflet where you have to stop the drug and to contact a doctor. I think that this is something that I have in mind for a long time, and I would like very much to discuss this further with other
maybe you could highlight some symptoms or signs that the patient should recognize as early symptom of something that can become very severe or serious. So this could be a good idea to improve the packaging of many drugs to have prevention of similar situation. Yeah.
Yes, I think that to highlight the early symptoms of very severe, now that we have the approach of risk management plan, where we are listing all the important risks, then we could say that for each important risk, we can highlight the early symptoms where you have to contact a doctor. Mm-hmm. Because this is an old drug, perhaps it's not so easy to do that. And a new drug, of course.
Yeah.
Of course, the prescriber could have prescribed the same drug. This for sure.
Maybe.
I am linking that between the prescriber and the academy. Are we sure that the prescribers are really thinking very quickly to link symptoms to an adverse reaction? I'm not sure about that. I would like to have your input on that.
I think that
even in the hospital, I'm not sure that they have thought about this.
No, the problem is that you know, the drug is some quite often, I would like to say, neglected by the prescriber are possible causative agent of any kind of adverse event, whatever. So of course, I know. I must confess I did this more in the past than very recently, but in the past there was a campaign of information to prescribers to consider always the drug one of the first causative agents for whatever the illness the patient are having. And so, for instance, based on this, you should start a sort of re-evaluation of patients with a deprescription pathway, you know, so that the patient, you have to adapt somehow the treatment of the patient to the situation, even and particularly in concomitance with the occurrence of new symptoms, of new illness, and so on. So I think that this could be a very good strategy to improve the situation.
So academy has a lot of work to do. And I think that this is what you're doing in when you're teaching.
Graduation and post-graduation, of course.
Yes.
Both.
Okay, so perhaps we can open all the microphone and ask for the participant if there are some questions. it seems that we have no question. I
Okay.
think that it was really a very interesting cases, and as you said, it's so rare to have such evidence, and fortunately that we don't have autopsy
Yeah.
to confirm our diagnosis. So I would like to present really thank you so much for this case. And we will now, I will now have a few slides to speak about the next event. And so I just wanted to speak about the next event. So in gray, you have the events in Hebrew. So whoever speaks Hebrew could attend this event. We have Itai Geta, who is physician in Sheba Hospital in pharmacology. After that, Priya Bari from IME will speak about the public hearing for Valproat. Ophir Lavon will speak about medication errors in Hebrew. We have a speaker from Peru, Yesenia Rodriguez, and myself who will speak about eculizumab and some specific adverse reaction. Then Victoria, the head of the Swiss chapter, will speak about propafenone and choline intoxication. And then we have Raquel Herrera Comoglio. She is the head of the LATAM chapter. So we have already a very full agenda of events. So stay connected. So in addition to the Tell Us a Safety Story series, we have planned some workshops. One will be about polypharmacy, deprescribing, and with an highlight on elderly patients. It was something that we have already planned before the COVID, and it was supposed to be done in Hadassah Hospital, but now it will be online. And we will have a biopharmaceutical biosimilars workshop. It will be a 4 hours event. And our big project is this event that we want to be international. We want to show all aspects of vaccination, the history, epidemiology, public health, because right now the anti-vax campaign have started very much and very high. So we have to give some explanation to the healthcare professional and to the general public to explain why it was so short to develop a new vaccine for COVID, which is now in few months will be available. And so we have to explain that because we have a lot of fears and distrust. And this will be done in collaboration with the chapters of ISOP, with ISOP International. We are in contact with members from WHO, from IME. So we are still building this program that will be certainly either a 2 days conference or a series. It's still something that we have to discuss. And of course, I was very proud, and it was difficult not to show you that in the ISO Patient Safety Day, we had a 2 hour session, and we were opening the session, the 2 days Patient Safety Days. So we are on the map. So thank you very much. We think that multidisciplinary, it's a key to the success of better to improve drug safety. And if you are interested, join us. Thank you very much and have a nice day or evening in front of you.
Bye-bye.
Bye-bye.
Bye.
Thank you so much.
Thank you very much.
Bye, Victoria.
Bye.
Thank you. Irene,
Yes.
כל הכבוד, and in English, it was really interesting. Thank you so much. Bye.
Thank you to all the participants from all over the world. It's really exciting. Bye-bye.
Thank you, Irene. Thank you, everybody. Bye.
Thank you, Judith from Bioforum for hosting us.
Okay,
And
I'm
organizing
closing.
this.
Thank you very much for being with us. It's okay. I'm closing the session.
Bye-bye.
Thank you.